Let's now look at the normal intrauterine pregnancy. Sonographic evaluation will begin at about the 4th week when the intradecidual sac can be first visualized. It's important to recognize, however, that until you see a yolk sac or an embryo, you cannot definitively diagnose an intrauterine pregnancy. Just like in real estate, it's all about location, location, location. If you look here, you've got your myometrium, your endometrium, and then your endometrial stripe. Think of this much like you would this cul-de-sac here. When you're building a home, you're not going to put the home in the middle of the road. Think of the endometrial stripe as being the road here, and think of the endometrial area here as being the yards. And you can see here, this is where the homes are built, that there's some border between the road here, and there's also going to be a border here, looking at these as being the backyard here, at the endometrial myometrial border. So remember, it's important to assess where the pregnancy is implanted. And here you can see endometrial stripe, that's the road. Here's the endometrium. Here's where the houses are. They're not out here in the myometrium. They're not very close to the edge here. And you'll see in a little bit as to why that's important. But really take a look at where the pregnancy is implanted, because that's a key thing to understand and to look for. Okay, so again, intradecidual sac. Here you've got this sonolucency here within the endometrium. Could it be an early IUP? Possibly. It's definitely the first sonographic finding of pregnancy, but it's not diagnostic of an early IUP. So anything before this approximate 4-week period of pregnancy, you're going to have a normal pelvic ultrasound. This is going to be the first thing that you see, but again, until there's a yolk sac or an embryo in there, you can't definitively call this an IUP, because there are other things that may look sonographically like an intradecidual sac, but they're not. Here's a transverse view here of an intradecidual sac, and what you can see here is there is, within the endometrium here, you can see here's the endometrial stripe, and it gets deformed a little bit here. So this is the intradecidual sac. It's implanted eccentrically within the endometrium, much like we had talked about earlier. It's not dead center in the endometrial stripe or the road. It's off to the side. The house is in the yard. Here we've got a closer look. Here you can see the endometrial stripe here. Here's the endometrium, and this is the myometrium here and here. So as we kind of sweep through, again you can see endometrial stripe, it's bowed a little bit here. You've got a decidual reaction, and here you've got this intradecidual sac. Here we have a patient, transvaginal sagittal exam. So this is a retroverted uterus because the fundus is back here. It's caudal, cephalad, anterior, posterior. Here you see this sonolucency or sac-like structure here. So is this automatically an intradecidual sac? It's in an unusual location. There's no surrounding decidual reaction. You definitely can't call it an intrauterine pregnancy because there's no yolk sac or embryo within it. But as we sweep through on this patient, you can see here we have an intrauterine pregnancy here within the endometrium. This is where you would expect it to be. And this one's actually a definite IUP because there is a yolk sac within it. What you were looking at earlier, this sac-like structure in the lower uterine or cervical region, is an Abothian cyst. So there are other things that can look like an intradecidual sac. When you see what you suspect is an intradecidual sac, you can take measurements of it to obtain a mean sac diameter. This has been found to be accurate to within 5 to 7 days menstrual age. However, it's important to understand you can do mean sac diameter measurements of a Nabothian cyst, of a decidual cyst, or any other structure that you want. So just because somebody tells you, I measured a sac and it's 5 weeks, 5 days, does not mean that it's definitively an IUP. Briefly mention here the double decidual sac sign. This was first coined by Nyberg back in the 80s, and this was before transvaginal scanning was routine, and because there was a longer window before you would end up seeing the yolk sac or the embryo just via the transabdominal window. Remember, if you don't see a yolk sac or embryo and you just see a sac-like structure, you can't definitively call it an IUP. So clinicians and researchers looked for ways to better understand the appearance of the intradecidual sac and to see if there were ways that you could definitively call it an IUP before the presence of a yolk sac. And Nyberg felt that this was a highly sensitive finding, that if you saw a double decidual layer around that sac, that went along with an early IUP. Since that time, there have been several small case series where people have shown pseudosacs of ectopics that appear to have a double decidual sac sign. So the bottom line here is it can help you to favor the diagnosis of an early IUP if you see the double decidual sac sign. But again, it's not 100%, and you still have to wait until you see the yolk sac or the embryo. Yolk sac, which you see here, it looks like a little Cheerio within the gestational sac, is the first definitive sonographic finding of an IUP. You're usually going to see this at about 5 to 5.5 weeks menstrual age and at about a quant of 5,000. It should have an echogenic ring and an anechoic center, and its inner wall to inner wall diameter should be less than about 5.6 millimeters. Here we have a transvaginal exam, sagittal and coronal windows in a patient with an anteverted uterus, and you can see here is the decidual reaction, the gestational sac, and there is the yolk sac within the gestational sac, and you can see it in two planes here. So this is a definitive early IUP. The presence of a calcified yolk sac, like you see here, is associated with pregnancy failure. It's not the cause of the pregnancy failure, but it's the result of the pregnancy failure here. And you can see on this transverse transabdominal sweep here that you've got this calcified yolk sac here. Here you have an embryo, and we'll talk about embryos in a little bit, but this embryo is greater than 5 millimeters and there's no cardiac activity, so this was a patient who had pregnancy failure. Here we've got a patient who also had a pregnancy failure and was in the process of miscarrying. On the sagittal exam here, you can see this is an anteverted uterus here. We're down by the lower uterine segment here, and you can see that the patient has a heterogeneous decidual reaction here. The sac has an irregular shape to it, which is not what you would like to see. Here you've got an enlarged yolk sac. It is echogenic with a central clearing, but a yolk sac that's greater than about 5.6 to 5.9 millimeters is associated with aneuploidy. If you look here, you can see another ring here, and this is the amnion right here. And here we've got a transverse view. There's yolk sac, and you can see some of the amnion here. So this was a patient who had pregnancy failure. The fact that the yolk sac is enlarged would lead you towards the possibility that the patient had aneuploidy. Let's now look at the embryo. You're usually going to see this by about 6 to 6.5 weeks menstrual age and a quant of about 13 to 15,000. If you have a crown rump length that's greater than 5 millimeters and you don't see cardiac activity, that's abnormal. You should also see the yolk or the embryo by a mean sac diameter of about 16 millimeters, and you should have seen the yolk sac by a mean sac diameter of 8 millimeters. Here we've got a coned-in view here, but here you've got the embryo within the gestational sac here. It's also within the amnion, and here you can see the yolk sac here. Measurement of the crown rump length is accurate to 5 to 7 days menstrual age. It's important that you do not include the yolk sac within the measurement. And once the embryo is advanced enough in age that you can notice flexion and extension, the crown rump length measurement should not be used, since if the fetus is in a flex position, you'll underestimate the gestational age, and if the embryo is in an extended position, you may overestimate the age. Here we have two inaccurate crown rump length measurements. Here you've got one where the yolk sac was included, so this would overestimate. Here you've got one where the calipers are inappropriately placed, so this would underestimate the gestational age. It's important to remember, if you want to be able to do these measurements, you have to be in the right preset. If you're in the abdominal preset or cardiac preset or renal preset, you're not going to have the option when you hit the calculation package to do these mean sac diameter or crown rump length measurements. So this is another reason why you want to make sure that you use the correct preset. In terms of embryonic cardiac activity should definitely be seen by a crown rump length of 5 millimeters. If you've got an embryo with a crown rump length of 12 millimeters without cardiac activity, that's consistent with pregnancy failure. However, with technology being improved in recent years, we're able to now see cardiac activity much earlier. It's not uncommon to see the flicker of cardiac activity when the crown rump length is just a couple millimeters. When you've got a crown rump length less than 5 millimeters, it's also not uncommon to see a heart rate in the 80 to 90 range. We traditionally think of embryonic or fetal cardiac activity being between the 110 or 120 and 160 range. If the crown rump length is greater than 5 millimeters, the heart rate should be in that 110 to 120 to 160 range. However, if the crown rump length is less than 5 millimeters, it's not uncommon to see a heart rate in the 80 to 90 range. So here we've got a video clip of an embryo with obvious cardiac activity. This is a more advanced embryo here. Here we have a very early embryo. This is the yolk sac here, and here you've got an embryo that measured about 2.3 millimeters. And if you look on the clip here, you can see the flicker of the heartbeat here. And this measured in the 90s, which for a more advanced embryo would be bradycardia, but for an embryo that's 2.3 millimeters, this is not abnormal. But here, take a look at this closely. You can see the flicker here in this very, very tiny 2.3 millimeter embryo. You document cardiac activity on a static image, you're going to use M mode. Here we've got a split screen image. This is the two-dimensional image. This is the M mode image here. And you can see here is the yolk sac here. The gate is over the embryo. And here you can see the cardiac activity on the M mode here, and we're able to calculate that, and the heart rate is 99. So this is going to be the way you can prove, whether you put an image on PACS or you put a thermal print on the chart, that the embryo was either viable or non-viable at the time of your scan. Take a look at this patient. Do they have an intrauterine pregnancy here? On the sagittal image here, you can see urinary bladder, here's vaginal canal, and this looks like the uterus here. This appears to be low. As we sweep through, you can see that there's cardiac activity here. But remember, it's important to diagnose an intrauterine pregnancy if you've evaluated the uterus in two planes. You can't just diagnose an IUP off of a sagittal image. When we look at this patient in the transverse plane, you can see here's uterus over here. Here you've got myometrium. Here's a thickened endometrium here. This pregnancy is off to the side over here. This is a right tubal ectopic. So you have to be very careful. You can only diagnose an IUP after you've seen it in two planes and have confirmed that it's within the uterus. So when you're attempting to diagnose an IUP, you've got to make sure that there's at least 5 millimeters of myometrium surrounding the pregnancy. There are a lot of things that can cause an asymmetric location. You could have an implantation site that's eccentrically located. You could have a contraction causing that appearance. You could have a bicornuate uterus, or you could have an interstitial ectopic pregnancy. Here we have a transverse exam of the uterus in a patient with a bicornuate uterus, and we're scanning at about this level right here. You can see here's myometrium, and here's myometrium. So you've got the right horn and the left horn here. This is a patient with a bicornuate uterus. So in a patient with a bicornuate uterus, you can see why the pregnancy could have an asymmetric appearance to it in terms of its location. We have a patient with a bicornuate uterus, and you can see that as we sweep up towards the fundus, you can see you've got the left horn and the right horn over here. And within the left horn, you can see that there is a pregnancy. And measuring here, there is at least 5 millimeters of myometrium surrounding this. So this was an intrauterine pregnancy in the left horn of a patient with a bicornuate uterus. Let's look at this patient. Do they have an intrauterine pregnancy? On the sagittal image, you can see the sweep here. Here's the pregnancy here. Here's the uterus here. So is this something that's eccentrically located? Let's take a look at the transverse view. And you can see on this sweep, here you've got uterus, here's pregnancy, but is this the right horn and this the left horn of a patient with a bicornuate uterus? If you take a close look here, there's no myometrium that's bordering this pregnancy here. There's no border here at all. So that would go against this being an intrauterine pregnancy. This was a patient who had an ectopic pregnancy. So this can be a difficult call, especially when you first begin scanning. My recommendation is that if you're having to measure, is there a 5 millimeter myometrial border, it's better to have a comprehensive scan done by somebody with more experience, because you don't want to misdiagnose a interstitial ectopic as being an intrauterine pregnancy. Here's another patient here. Let's take a look at this transverse view on an endovaginal exam. So here we've got the uterus here, and here you've got this eccentrically located sac. There was a yolk sac in it, so it is a pregnancy. Now the question is, where is it located? And if you look, it is very eccentrically located. Here you don't have any myometrial mantle surrounding it, which is of concern that this is an ectopic pregnancy. If you take a look on the sagittal exam, you can see there's the sac. And you can see that it's actually in the mid-uterine range here. It's not in the area of the uterine fundus here. It's sitting right at this location right here. So this was not an intrauterine pregnancy. Again, there's no myometrial mantle surrounding it here. It's in a low position anterior. This is a patient who had a cesarean section scar ectopic pregnancy. Even if you don't recognize that that's what it is, the fact that this was so eccentrically located should have set off red flags for you. How about this patient? Do they have an intrauterine pregnancy? So here's the sagittal view right here. It's an anteverted uterus. Here's vaginal stripe right here. If you look at this area right here, at first you're going to want to say that's the bladder. But if you look right here, there's no wall, so that does not fit it being the bladder. This is actually the bladder here. It's being compressed. As we sweep through here, there's fluid in the cul-de-sac here. You can also see this area right here that's kind of gelatinous in appearance. It's kind of shimmering a little bit. This is clotted blood. This is free fluid here in the anterior cul-de-sac. On this limited sweep in the sagittal plane, I don't see a definitive intrauterine pregnancy. As I go transverse, here you've got a sac with a yolk sac in it, but again, this is very eccentrically located to the right side of the uterus. This is a transabdominal transverse image here, and I don't see a myometrial mantle surrounding this. And again, there's no myometrial mantle here surrounding this area here. So this is a patient who had a ruptured right interstitial ectopic pregnancy. Here we have a patient who has a dichorionic diamniotic pregnancy. There's two discrete sacs here. So when you're dealing with someone who's got a multiple pregnancy, you want to diagnose, if at all possible, the chorionicity and the amnionicity, because it's going to be easiest to determine during the first trimester scan, and this has significance to the obstetrician caring for the patient. In terms of diagnosing a twin pregnancy, you only want to document a twin pregnancy if you see a yolk sac or an embryo. It's the same as diagnosing a singleton pregnancy. In terms of nomenclature, the embryo that's going to be closest to the cervix is going to be pregnancy A. Here we have a patient with a dichorionic diamniotic pregnancy. You can see here is one amnion, and you can see here's the second amnion, and they're contained within two different chorionic sacs here. And here's a transverse view. Here's one pregnancy, and here's the second pregnancy. So this is a dichorionic diamniotic twin pregnancy. Let's now look at the abnormal intrauterine pregnancy. Subchorionic hemorrhages are commonly seen. They are abruptions of the placental margin causing elevation of the chorionic membrane. The size of the hemorrhage is going to be the most important predictor for pregnancy failure. Here you can see an echogenic subchorionic hemorrhage surrounding this pregnancy here. It's very small. Chorionic hemorrhages can be either anechoic or echogenic, and they usually will have a falciform shape due to the fact that it conforms to the shape of the uterus. So here you've got a subchorionic hemorrhage that extends approximately 50% around the gestational sac. As opposed to using terms like blighted ovum or an embryonic pregnancy, I prefer using terms such as definitive pregnancy failure or possible pregnancy failure, definitive intrauterine pregnancy, possible intrauterine pregnancy, definitive ectopic, possible ectopic. To diagnose a definitive pregnancy failure, you're going to need to see an embryo greater than 5 millimeters without cardiac activity. To have a possible pregnancy failure, you need to have an irregular sac that does not have a yolk sac by 8 millimeters mean sac diameter, or no embryo at greater than 16 millimeters mean sac diameter. Here is evidence of definitive pregnancy failure. You've got an embryo here that's greater than 5 millimeters and you have no fetal cardiac activity. Be careful when using ultrasound to diagnose a completed miscarriage. The diagnosis cannot be made with certainty with ultrasound. In a patient with a completed miscarriage, you're going to have a normal pelvic ultrasound. There'll be no definitive placental or fetal tissue seen. If you've got a patient who came in, you've got witnessed fetal parts passed, that helps in making the diagnosis easier when you couple this with your physical exam. However, a lot of patients will tell you that they passed the tissue at home when in reality they just passed clots and they've got an occult ectopic. So you've got to be very careful about using ultrasound to confirm that someone's had a completed miscarriage. The diagnosis of an incomplete miscarriage should be made in conjunction with your physical exam findings. Ultrasound findings include obvious presence of placental or fetal tissue, which makes it a no-brainer. Non-specific finding would be endometrial thickness greater than 10 millimeters. If you rely on this finding alone, you would take a lot of women to the operating room for D and C unnecessarily. If you've got what appears to be a heterogeneous fluid collection within the endometrium, put color Doppler on it. If you can verify the presence of feeder vessels like you see here, then this helps confirm that there's retained placental parts, and you can make then the diagnosis of an incomplete miscarriage. With molar pregnancy, most of the findings that have been described are ones that you're going to find in late first trimester, early second trimester, where you're going to have an enlarged uterus, an abnormally high quant, and sonographically you're going to have the classic cluster of grape appearance. You're going to have complex mass within the endometrial cavity with multiple small cystic spaces. In early first trimester, the findings of a molar pregnancy could look very similar to the findings of pregnancy failure. So you would need to couple this with the quant, but you have to be very careful. The classic findings described in the literature pertain to late first trimester, early second trimester findings. Here's a patient who is about 6.5 weeks pregnant. You can see within the endometrium here, there's this multiple cystic area. There are multiple cystic areas. And on the transverse view, you can see the same thing here. There's no definitive IUP, but you can see that the endometrium is heterogeneous and there's multiple cystic areas. If the quant on this patient was 485, this could go along with hydropic degeneration and pregnancy failure. However, this patient had a quant of approximately 65,000. She was followed up and the quant kept rising, and she was taken to the OR where the diagnosis of a molar pregnancy was confirmed. Let's take a look now at ectopic pregnancy. Definitive diagnosis of an ectopic pregnancy requires that you visualize a yolk sac or embryo outside of the uterus. The most common type of ectopic pregnancy is going to be a tubal pregnancy that's in the ampullary region of the tube. Since this introductory lecture is going to focus more on intrauterine findings as well as findings of the cul-de-sac, are there any intrauterine findings that could help you in leaning towards a diagnosis of an ectopic? Well, the endometrial findings associated with an ectopic pregnancy are variable. You'll get a pseudosac in about 10 to 20% of cases. Endometrial thickness can be variable, so this can't be used to rule in or rule out an ectopic pregnancy. However, a trilaminar appearance of the endometrium is highly specific for the diagnosis of an ectopic, but the sensitivity is low, so if you see it, this should point you towards the diagnosis of an ectopic pregnancy. Here's a patient with a pseudosac. You can see here's the road, the endometrial stripe, and this is literally in the road here at the end of the cul-de-sac, and this is just a decidual cast from the hormonal reaction from the ectopic pregnancy. So this is going to be located centrally in the endometrial cavity, and in theory there should only be one layer present. However, there have been cases described where a double decidual sac appearance was present. Here we have two patients, both of whom had ruptured ectopics. The patient on the left here has an anteverted uterus on this sagittal exam. There's no intrauterine pregnancy seen, and you've got complex fluid in the anterior and posterior cul-de-sacs. And if you look, the endometrial thickness is relatively thin. Here we've got a patient who has a ruptured ectopic. Her uterus was retroverted here, but they have a nice thick endometrium. And here you can see the ectopic pregnancy here, and there's some free fluid here. So here's one with a thick endometrium, here's one with a thin endometrium. Both had a ruptured ectopic. So the endometrial thickness cannot be used to make or exclude the diagnosis of an ectopic pregnancy. Here's the trilaminar appearance where you have three lines. You have 1, 2, 3. This is essentially the appearance that you would expect to see in the follicular phase of the menstrual cycle, not what you would expect to see in the luteal phase or in early pregnancy. So if you see this, it's considered to be specific for the diagnosis of ectopic pregnancy. Here's another patient who had an ectopic pregnancy. Here you can see 1, 2, 3 lines. This is a Trilaminar Appearance here, and this was a patient with an ectopic pregnancy. Now with free fluid, you can have small amounts of simple or anechoic fluid in the cul-de-sac, and that can be normal. And it's important to remember, hemorrhage can either be anechoic or echogenic. However, if you see echogenic fluid, regardless of the amount, it's hemoperitoneum until proven otherwise. Here's a sagittal view here of an anteverted uterus. There's no IUP seen. You've got some fluid in the posterior cul-de-sac here, but it appears anechoic. However, if you look here in the anterior cul-de-sac, you see complex appearing fluid. This was a patient who had a ruptured ectopic. When you have a patient that you're suspicious has a ruptured ectopic, I would always advocate performing a perihepatic window, because if you see fluid in the perihepatic space, this is clearly abnormal. It will never be physiologic, and several studies have shown that patients who have ruptured ectopics and have fluid in Morrison's pouch, there's a high need for surgical intervention on these patients. Here we have a patient with complex fluid in the cul-de-sac. If you look, there's fluid going along the back wall of the uterus here. It's an anteverted uterus, a sagittal view, but you can see there's echoes within here. And note the nice triangular corners here that you would expect with free fluid in the peritoneal cavity. But this patient has echoes. Even if this was a very small amount of fluid, the fact that it has echoes means there's hemoperitoneum until proven otherwise. In a non-pregnant patient who is febrile, remember, ultrasound cannot differentiate between purulent debris and hemorrhage. So a patient with a temp of 102, 103 who comes in with symptoms of a TOA, this could be pus. So just keep that in mind. Here's a patient that has a very large amount of hemoperitoneum, and it's all complex. If you look here you've got the uterus. It's anteverted here. You can see that there's triangular corners here as the fluid is interacting with the bowel the whole way around the uterus. And up here into the anterior cul-de-sac, there's a very large amount of complex fluid here. There's no intrauterine pregnancy seen. The findings of no intrauterine pregnancy and the presence of a large amount of complex free fluid is consistent with a ruptured ectopic in this pregnant patient. It could also be possible that this patient could have hemorrhage due to rupture of a corpus luteum cyst, but regardless, this patient has a large volume of hemoperitoneum and is going to require surgical intervention. Here's a patient that had a ruptured ectopic and had a large volume of clotted hemoperitoneum. When you look, here's the sagittal transabdominal view. The first thing you have to do is define the outline of the uterus. And here you can see it coming along here, coming over to here, and over to here. So you can see these complex areas surrounding it. Here you've got free fluid here. There's no wall around it, so that's not the bladder. This is the bladder. This is complex fluid here. There's no intrauterine pregnancy seen. So in this pregnant patient, this is consistent with ruptured ectopic until proven otherwise. Here's the transverse view here. You can see the uterus right here. Here's the ectopic pregnancy. But even if you couldn't recognize the ectopic pregnancy, the fact that you've got no intrauterine pregnancy and a large volume of hemoperitoneum warrants emergent obstetrical consultation and operative intervention. So does this patient have hemoperitoneum? This is one where the initial clinician performing the exam missed the presence of hemoperitoneum. And if you take a look at this exam closely, you have to ask yourself, where is the uterus? And the uterine outline is right in here. So it's an anteverted uterus. And this is all complex fluid in the cul-de-sac wrapping around into the anterior cul-de-sac. There's no intrauterine pregnancy seen, so this is a patient who has a ruptured ectopic until proven otherwise. The The fact that there's no anechoic free fluid made it easy for the clinician to miss this. So you got to be aware of the presence of echogenic free fluid. And don't forget to do the perihepatic window if you're suspicious for ruptured ectopic. That's going to be an intercostal oblique window with the indicator directed towards the patient's head, somewhere between the 8th and 11th intercostal spaces at about the mid-axillary line. That'll give you this image: lateral, medial, head, foot. You've got liver, you've got kidney, you've got perinephric fat here, and you're going to look for free fluid here in the peritoneal space. Here's another image on a patient. No perinephric fat is seen here, so you're going to look for fluid coming along the border of the liver here into Morison's pouch. And here's a patient with a positive right upper quadrant window. You can see here's liver, here's kidney, here's perinephric fat. So this is true capsule of the kidney. This is Gerota's fascia. This is going to be Glisson's capsule surrounding the liver. And here you've got hemoperitoneum surrounding the liver here and interacting with bowel here. So this was a positive right upper quadrant window. Let's look at some clinical pearls on how to best use this focus study. If you see an intrauterine pregnancy in a stable patient with a benign exam, no free fluid, and they don't have any significant heterotopic risk beyond the general population, and you're not concerned about another etiology for their abdominal pain, these people can be discharged home if stable with follow-up. What if you see an intrauterine pregnancy, no free fluid, but this is a patient from the assisted reproduction clinic? These patients have a 1 in 150% chance of having a heterotopic pregnancy, so these patients need comprehensive sonographic evaluation for heterotopic pregnancy and close follow-up. What if you don't see an intrauterine pregnancy and free fluid is seen? Particularly if you see free fluid in Morison's pouch, these people need emergent obstetrical consultation. They should be considered to be a ruptured ectopic pregnancy with hemoperitoneum until proven otherwise. What if you have a patient who has no intrauterine pregnancy, no free fluid seen, and a quant less than 1,000? Remember, since all we've done with this study is look at intrauterine and cul-de-sac findings, we have not addressed the adnexa, so these people need comprehensive scans since their differential includes early IUP, occult ectopic, or pregnancy failure. So remember, focus at this point on intrauterine findings both transabdominally and transvaginally, as well as cul-de-sac findings. In future modules, we're going to build on how to evaluate the adnexa more successfully